Division of HIV/AIDS Prevention, National Center for HIV Viral Hepatitis, STD and TB Prevention at CDC. Now let's all say that together. My office was established in September of 2010, and we have been tasked with monitoring our division's performance around the national HIV/AIDS strategy for the U.S. that was released in July of 2010. It's important that we all pay equal attention to the social context where people live and where behaviors are shaped, as well as to the more traditional concerns of public health, such as things like improving access to quality care, ensuring that people make healthy choices, being concerned about primary prevention. And that is the goal of the lecture that we're having today. And it is my esteemed pleasure to welcome you here to the HIV/AIDS 30 Years of Leadership and Lessons lecture series on behalf of the CDC's Division of HIV/AIDS Prevention and our National Center. And we are grateful to the Morehouse School of Medicine and to the Satcher Health Leadership Institute for use of this facility, and to all of you for joining us. And as many of you know, 2011 marks the 30-year anniversary of the first MMWR publication on HIV and AIDS. And these series of lectures then were designed to raise awareness about the strides that have been made in the HIV/AIDS epidemic, and also, which is really important, for us to provide a platform to examine the successes and challenges that have been made over the past 30 years. My office had the pleasure of working to create this particular lecture, and it's one of 9 that's being hosted throughout the summer to closely examine defining moments that have changed the course of the HIV/AIDS epidemic. So I want to give you briefly the goals of our lecture for today, and that is to provide you, one, with a historical perspective of the social injustices that have contributed to what we see now as the current state of the epidemic, and then to discuss some of the most important issues regarding the social determinants of health in their context area, and then to discuss ways in which our community partners, including you, can work with us to address those social determinants and then, in turn, eliminate inequities in HIV prevention. So what I'm going to do is to briefly introduce each of our speakers, and then they are going to, in turn, come and provide you with their perspectives to achieve the goals that I just mentioned. Followed by the last speaker, we'll have our Q&A period, and we have designed the lecture to have a very robust period of time for you to provide your questions and answers, and we do hope that this will be an interactive discussion. So to start the conversation, we have Dr. Kevin Fenton, who is the director of the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention at CDC, and he is going to provide an overview of the current epidemic, as well as discuss the national HIV/AIDS strategy for the United States as it relates to social determinants of health and health equity. In November 2005, Dr. Fenton was named the director of the National Center, and prior to that appointment, he was chief of CDC's National Syphilis Elimination Effort. Dr. Fenton has both M.D. and Ph.D. degrees and has worked in research, epidemiology, and the prevention of HIV and other STDs since 1995. He was previously the director of the HIV and STI department at the United Kingdom's Health Protection Agency. He spearheaded there the development of a number of national HIV, STD, and behavioral surveillance and research programs in the UK as well as Western Europe. And that includes the National Chlamydia Screening Program in England, the second British National Survey of Sexual Attitudes and Lifestyles, and the European Surveillance of STI Network. He is a Fellow of Public Health of the Royal Colleges of Physicians of the United Kingdom. Dr. Fenton. Our second speaker, Dr. Bill Jenkins. Eliminating health and healthcare inequities requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequities and historical and contemporary injustices. And it is equally important to understand and appreciate the history of healthcare injustices and its role in eliminating health disparities. So, Dr. Jenkins, then, an epidemiologist, who was retired from the CDC, where he helped to end the infamous Tuskegee syphilis study of untreated syphilis in the Negro male, will address those issues. He also established numerous initiatives to improve public health. Dr. Jenkins holds the Ph.D. and MS degrees, and he completed his education at Morehouse College, Georgetown University, and the University of North Carolina. Currently, he's with the Institute of African American Research at the University of North Carolina, Chapel Hill, in the Gillings School of Global Public Health. Dr. Jenkins. Our next speaker, Dr. David Satcher, was appointed in 1998 by President Bill Clinton as the 16th Surgeon General of the United States. Dr. Satcher, also a Morehouse College grad, brought national focus and recognition to disparities in health status and healthcare access and quality for minorities. So today, Dr. Satcher is director of the Satcher Health Leadership Institute at Morehouse School of Medicine. He established this institute in 2006 to develop a diverse group of public health leaders, to foster and support leadership strategies, and to also influence policies and practices toward the reduction and elimination of disparities in health. Dr. Satcher. Our last speaker, Dr. Miriam Vega, is Vice President of the Latino Commission on AIDS, and she'll close out today's lecture. She was appointed the Vice President of LACOA in 2010. And prior to that appointment, she served as the Director of Research and Evaluation there. She spent 6 years pioneering and leading the development of the Capacity Building Assistance Division, and she also founded the Research and Evaluation Department there. She was educated at Vassar College and the University of California at Berkeley. Her dedication, professional track record of success, and her work in the community make her public health perspective very noteworthy. She will discuss the role of community partners in addressing HIV-related health equities. Dr. Vega. Please join me in welcoming Dr. Fenton to the podium.
Thank you very much, Donna, and good evening, everyone. Thank you so much for joining us for this incredible moment where we are going to have some time to reflect on the role of social determinants of health and its connection with the U.S. HIV/AIDS epidemic. I want to begin by thanking the Satcher Health Leadership Institute and Morehouse School of Medicine for hosting us this evening, and I'd like to thank my colleagues at the CDC for their leadership in pulling this lecture series together. Great, so the purpose of my talk this evening is really to begin by setting the scene and reflecting on where we are with the epidemic of HIV/AIDS in the United States. And for the next 15 or so minutes, what I'm hoping to do is to provide that broad overview of the HIV/AIDS epidemic in the US, and then I'm going to briefly reflect on what we now understand to be the role of the social determinants of health on both driving the epidemic of HIV/AIDS in the United States and contributing to some of the tremendous disparities which we continue to see with this epidemic 30 years into its evolution. And then finally, I'm going to reflect on the national HIV/AIDS strategy. As many of you are aware, we celebrated the first year's release of the national HIV/AIDS strategy only yesterday, and what a year it's been. So with the role of this new strategy, with this incredible energy around thinking differently about ending the epidemic in the United States, I'm going to end my presentation today by just reflecting on some key CDC contributions and activities associated with the national strategy. So let's begin then by going back in time, but also thinking about where we are today with the HIV epidemic in the United States. I think there's 5 key features of the US epidemic that I really wanted to maybe begin by summarizing first before going into the data and dazzling you with graphs and charts. I think if I had to say what are the key features of the epidemic in the US, I'd begin by saying it's a very dynamic epidemic, one which continues to change as we speak. We're seeing increasing concentration of the epidemic among socially disadvantaged communities in the U.S. We're seeing tremendous changes among men who have sex with men and injecting drug users. There are lots of areas where we're making tremendous progress in the United States, but there's still pockets of deprivation. There are still pockets where we're seeing high incidence of HIV in the United States. Part of this concentration of the epidemic is actually seen among men who have sex with men, persons of color, and certainly in geographic areas across the United States. So if we're thinking about the epidemic today, it means that we must know today's epidemic and not the epidemic of 10, 20, or 30 years ago in order to properly target our prevention efforts and to focus the scarce resources that we have for greatest health impact. We're seeing growing prevalence of HIV infection in the United States as more people live longer and healthier lives with HIV. And in some sense, this is perhaps the good news of the epidemic, that we now have effective antiretroviral therapies which are making tremendous differences in the lives of people living with HIV. Nevertheless, because we continue to see stable HIV incidence in the US, we're adding each year to the numbers of individuals who are living with HIV. And so therefore, this should focus our hearts and minds to think about ways in which we should be getting ahead of the epidemic in the US. I mentioned some key signs of success that we're seeing in the US, and no discussion on the journey, the 30-year journey of HIV in the US would be complete without acknowledging the hard work of so many of you in the field and your contributions to making real signs of success with the epidemic. Whether it's the declining transmission rates in the US, where we're seeing fewer new infections relative to the prevalent body of HIV infections in the US, declines in new infections and diagnoses among injecting drug users, among mother-to-child transmission of HIV, which is almost eliminated in the United States, stabilization in deaths from HIV, and stabilization in AIDS cases in the United States. These are real signs of success, and as we toil to see further success in the epidemic, we must acknowledge these successes. And then finally, as I mentioned, a fifth key area where I think we need to focus on are areas of what I call areas of grave concern, really focusing on where the epidemic is most concentrated today. And we know from our epidemiological data that these include young men who have sex with men, particularly African American and Hispanic and Latino men who have sex with men. We have to focus on African American women who bear severe and disproportionate burdens of HIV compared to other women in the United States. We need to think about emerging communities, such as the Hispanic and the Latino communities in the United States, where we're seeing changes in the prevalence of HIV, which cause tremendous concern. And finally, what I call hyperendemic locations within the US. And you know these locations. They include Atlanta. They include central LA. They include Washington, D.C., New York, parts of Florida, where we're seeing high concentrations of disease associated with socioeconomic deprivation as well. So I wanted to begin by these 5 overarching features of the U.S. epidemic, because as we have the conversations this evening about the social determinants of health, we'll begin to see why these social factors continue to drive the patterns of disease we're seeing in the U.S. today. So let's look at some of the numbers. I hope all of you in the room are aware that in the U.S. we have about 1.1 million Americans who are currently living with HIV, and about 1 in 5 of those individuals remain unaware of their HIV status. So this is critically important to our prevention efforts, because if we are going to reduce the rates of new infections, we have got to diagnose individuals and support them to reduce onward transmission of HIV. Every year we see about 56,000 new HIV infections, and this level of new infections or HIV incidence has been relatively stable since the late 1990s. That is not good enough. We have to look at ways in which we should be driving down the numbers of new HIV infections in the United States. And again, we're seeing stabilization in the number of new diagnoses. Each year, just over 40,000 individuals are becoming diagnosed with HIV. But again, because we're seeing about 15,000 people dying each year as a result of HIV/AIDS, each year we continue to add nearly 40,000 people to the prevalent pool of HIV in the United States. So the overall picture of HIV is really summarized here in this graph, which really shows the trends in the prevalence of HIV, the number of people living with HIV, highlighted in the red bullets or red dots on this chart, as compared to the number of new HIV infections in the United States, illustrated in blue. And clearly here we see the stabilization in HIV incidence relative to the rapid growth and the sustained increases in the prevalence of HIV in the United States. Now, one of the key and very dynamic features of the U.S. epidemic is that the epidemic itself is not randomly distributed across the United States. And there are some U.S. states which bear a much more severe burden of HIV than others. And this burden has been shifting dynamically over time. So many of you may recall that at the beginning of the HIV epidemic, we heard the first reports coming from the eastern seaboard, New York, and the western seaboard, California. And the early cases of HIV were largely associated with the states which had perhaps more metropolitan, larger populations of men who have sex with men. Over time, however, we've seen this dynamic evolution of the epidemic, and increasingly we're seeing more and more new infections and higher burden of disease occurring in the southeastern parts of the United States, which may be associated with higher populations of African Americans and Hispanic and Latinos, which in turn bear a disproportionate burden of HIV. But we also know that there are tremendous economic variations across the United States. And of course, in the southeastern U.S., we have to be particularly concerned about the burden of HIV among rural populations as well, the rural poor, especially in the U.S. So this really just shows you pictorially about the changing patterns of disease within the United States and the increasing burden of disease that we're seeing, especially in the southeast and in the border parts of the U.S. Now, what's not shown here are some of the U.S. territories which have even more severe rates of HIV, whether we're reflecting on the epidemic in Puerto Rico, in the U.S. Virgin Islands, or some of the other smaller areas where we have low populations but high numbers of HIV diagnoses. So health inequity is a real and sad characteristic of the epidemic in the United States. Because of the time I have available this evening, I'm not going to focus too much on presenting a lot of epidata, and what I'd like to do here is just to highlight some of the most, what I consider to be some of the most staggering epidemiological statistics that we're dealing with the epidemic today. Now, 95% of people who are currently living with HIV/AIDS in the United States are either men who have sex with men of all racial and ethnic backgrounds, they're either African Americans or Hispanic and Latinos or injecting drug users. So this gives a sense of the concentration of the infection, especially among these population subgroups. Men who have sex with men are more than 40 times more likely to be HIV infected than other men and women in the United States, again illustrating that concentration of disease among men who have sex with men. Many of you are aware of the racial and ethnic disparities that we see in the United States. African Americans are 8 times more likely, and Hispanics and Latinos 3 times more likely to be HIV infected or to be living with HIV compared to white Americans. 54% of persons living with AIDS in the United States actually live in 5 states of the Union, again highlighting the highly concentrated nature of the epidemic that we have in the US. And 90% of persons with HIV/AIDS actually live in 23 states. So again, this should help us to both prioritize where we focus our resources and where we focus our prevention efforts if we're thinking about new ways of tackling the epidemic in the US. And another increasing feature of the epidemic related to health equity is the concentration of disease in urban areas where HIV prevalence, especially among heterosexuals in the lowest income strata, are nearly 6 times higher than that in the highest income stratas in those urban areas. So whether we're looking in Washington, D.C. or in Chicago, here in Atlanta, the poorer you are, the higher the prevalence of HIV we're likely to see. And one of the key findings that we're seeing, especially in these socioeconomically deprived areas, is that as you become much more socioeconomically deprived, we see less racial and ethnic variations. In other words, it doesn't matter if you're white, Hispanic, or black. If you're poor or living in some of the poorest areas in urban parts of the United States, you're equally likely to have a high HIV prevalence. Another key area of concern is the issue of undiagnosed HIV in the U.S. I earlier mentioned that about 1 in 5 Americans are currently living with HIV but unaware of their HIV status. And again, this is not randomly distributed. We see higher levels of undiagnosed HIV infection according to the racial and ethnic groups, with groups such as Asian Pacific Islanders having some of the highest levels of undiagnosed infections, and whites having among the lowest levels of undiagnosed infections. We also see tremendous differences across the transmission risk categories as well, with heterosexuals, especially heterosexual men. Nearly 1 in 4 heterosexual men living with HIV are unaware of their HIV status. Just over 1 in 5 men who have sex with men. We are doing a much better job of reducing undiagnosed HIV infections among injecting drug users. So given this epidemiological data and given the patterns now that I'm describing related to health inequity, what does this mean for the way we should be doing HIV prevention in the United States? I think there are some key things that we need to be doing and thinking about differently if we're going to really change the direction of the course of the epidemic in the United States. The epidemic concentration, which I've described so far in this presentation, really suggests to me that we should not be distributing our resources randomly across the United States, but we really need to be focusing these resources where the burden of disease is highest and where new infections are likely to occur. So we need to prioritize, target, and bring to scale the most effective interventions in those jurisdictions which need them most. I think the current economic realities dictate that we really need to be using our resources more effectively. And I think the days of allowing jurisdictions or to allow 1,000 flowers to bloom and to allow a range of creativity in prevention efforts across the country perhaps need to change. We have a more robust prevention toolkit. We know about the most effective prevention interventions, and we know how best to apply these interventions given the phase of the epidemic. And I think, given these economic realities, we need to be, both at the CDC as well as at states, as well as in the local jurisdictions, far more directive in ways in which we align our resources, the ways in which we use our resources, the ways in which we invest and monitor the epidemics for greatest impact. We now know that the drivers of the HIV epidemic in the United States are not simply the result of high-risk sexual behavior occurring at the individual level. And we'll be speaking more about the social determinants of health. But given what we know today about the multi-layered determinants of HIV transmission, I would argue that this really calls for us to be thinking about not only individual-level interventions, for example, counseling, encouraging individuals to use condoms, etc., but we must look at interventions which are targeting both sexual networks, communities, the society more generally. And this multi-layered approach really behooves us to have a much more balanced prevention portfolio moving forward. And I'll be discussing what this balanced portfolio could look like from a social determinants perspective. Finally, in a transformed health system with a lot of buzz currently in place regarding health reform in the United States, we perhaps need to be more nimble in thinking about the opportunities which will present themselves through the Affordable Care Act to ensure that we are looking at issues such as assessment, assurance, and quality of our interventions, strengthening our surveillance systems, and looking at new ways to leverage other parts of the health sector to help us in the HIV prevention and control efforts. So I think these are some of the emerging implications that I see from our role at the CDC and the new directions in which I think we need to go. Now, in the second part of my brief talk, I really want to just go a little bit deeper in these social determinants of health, to unpack them a little bit more and to perhaps demonstrate just how dynamically things are changing in the United States. Now, I hope all of you here are very familiar of the WHO's framework for the social determinants of health, which for the first time unpacks the multiple layers of influences on health in any given population and stratifies it by those social determinants, for example, socioeconomic context, governance within our states, cities, and countries, policies which are in place which can either facilitate or hinder our prevention efforts, and of course those cultural and societal norms which frame the way we deliver and develop services and the ways in which we engage communities. The social determinants of health framework also talks about the individual and the role of that individual, both in terms of their behaviors that can result in high risk of acquiring infections or chronic diseases. But this model is novel and unique in thinking about where individuals are within the social hierarchy and what are some of the factors which influences the way society relates to individuals within communities or within countries or any given setting. So, for example, factors such as education, occupation, income, gender, ethnicity and race, and I would also add to this list sexual orientation, can have a huge influence on how that individual is placed within any given society and how that society relates to that individual, and in turn, that has an impact on their health. Clearly, the healthcare system, highlighted at the bottom of this chart, is going to be a huge influencer on health outcomes. And then finally, thinking about some of the individual level factors, material circumstances, issues around social cohesion, the robustness of communities and their abilities of communities to respond to epidemics from a point of resiliency rather than from a point of deficiencies are critically important in this model. Now, I'm sure you'll be hearing much more about the model from the other presenters today, so I'm not going to dwell on this any further. But I really wanted to perhaps unpack some of these just to give you a sense of why it's important to understand these determinants and how this understanding should really help to change the way we do business at CDC. So clearly, if we believe that social policies and governance and cultural norms have a huge role to play in access to healthcare, or ability to encourage HIV testing, the ways in which we develop and deliver prevention programs, we need to be tackling and thinking about cultural norms and societal norms. We need to have a whole new conversation about the role of stigma and discrimination and the role that it continues to play in driving HIV in the United States. We need to think about homophobia, both overt and covert homophobia, and homophobia which is instilled within our organizations, and ways in which we need to be addressing that as a structural intervention in the United States. And clearly we need to be thinking about resilience of communities as well. These are data that I'm just putting here just to illustrate some of the unique challenges that we're going to be facing in the US, given, for example, the economic downturn that we're currently experiencing, and the tremendous disparities that we're seeing between the very rich and the very poor within our society. And as society becomes even more unequal, the tremendous impacts that that's likely to have on some of our ability to actually both deal with the epidemic, but also the increasing concentration of the epidemic that we're likely to see. So this just really pictorially shows a very dramatic change in the differences between the top 1% of earners in the US and the bottom fifth in blue of earners in the United States. And this understanding these economic realities are critically important because we see this reflected in people who are living with HIV/AIDS in the US. These are data taken from the US Census and other employment sources, which really shows that whether you're looking at the differences by income, those earning less than $10,000 in the United States, or the differences in the proportion reporting being unemployed in the US, people living with HIV are far more likely to be unemployed or have low incomes than the general population in the US. And this is, again, likely to get worse as we're experiencing the economic downturn. This can have a tremendous impact on our ability to deal with the epidemic. We need to think about social norms and values and the ways in which the US population is currently conceptualizing the epidemic. Is it an emergency? Is it a crisis? Should we be doing anything with the epidemic? And how does the epidemic today fit relative to other challenges that people are experiencing, with high unemployment rates, with people looking for jobs, having difficulties accessing healthcare? Well, data from the Kaiser Family Foundation suggests that Americans are seeing HIV/AIDS less and less as an urgent health problem facing the nation, and they've been tracking these data over time from 1995, where 44% of the population identified HIV as a major health problem, to less than 6% in 2009. This has a tremendous impact at the societal level on our ability to engage the hearts and minds of the general population, of all Americans, about the crisis of HIV/AIDS. This has an impact on our ability to argue for additional resources to be placed into HIV prevention, treatment, and care. This has a direct impact on our ability to tackle stigma and discrimination if so many of us, of our brothers and sisters, do not feel that HIV/AIDS is a problem today. So again, you'll hear much more in terms of some of those societal level impacts and ways in which we can address those from other presenters today. In the final part of the talk this evening, I'm going to briefly reflect on the National HIV/AIDS Strategy, and I just really want to share with you my elation that for the first time the US has a unified vision for what we want to achieve as far as HIV is concerned in this country. And the vision of the National HIV/AIDS Strategy is simple, and it's clear, and it's compelling. The United States will become a place where new infections are rare, and when they do occur, every person, regardless of age, gender, race, ethnicity, sexual orientation, gender identity, or socioeconomic circumstance, will have unfettered access to high-quality, life-extending care, free from stigma and discrimination. This vision is critically important for everything that we are doing at CDC, and I would dare say in certainly other federal agencies, as we now align ourselves with this national strategy. It talks about issues which are driving social inequalities in the HIV epidemic in the US today. It talks about the realities of the socioeconomic circumstance and the importance of taking that into our consideration as we develop our programs. And it talks about access to care, life-extending care, and of course the importance of stigma and discrimination. The strategy itself has three overarching goals: to reduce HIV incidence, to increase access to care for people living with HIV and to optimize health outcomes, and thirdly, to reduce HIV-related health disparities. And it is clear in the strategy that this cannot be achieved unless there is better coordination across federal agencies, better partnership between federal agencies, the private sector, and there is full engagement of communities and the hearts and minds of Americans from every walk of life. These are key tenets of the National HIV/AIDS Strategy, and I hope you share with me the excitement of having this national plan and having this national voice and vision for change in the United States. Now, CDC has been realigning our efforts with the publication of the national strategy, and I'm just going to highlight here some of the exciting developments that we've put in place over the last year. In our efforts to focus on reducing HIV incidence, we have recently changed the way we're going to be funding HIV prevention by health departments in the United States, allocating key resources to better align with the changing epidemiology of HIV, but also being far more directive in targeting the resources on highest impact, scalable interventions to deal with local epidemics more effectively. We're changing the way we monitor and evaluate the HIV epidemic in the US so that we can get better real-time information on the epidemic in the United States, so that we can do mid-course corrections and we can better target our interventions to meet the needs at the local level. We're scaling up HIV testing in the US in an unprecedented way, and this has been part of a long-standing commitment for CDC for the last 5 years to increase the proportion of Americans who are aware of their HIV status, because that is the gateway to effective treatment and care if you're positive, and if you're HIV negative, to take steps to protect yourselves from becoming infected. So these are some new interventions or expanded interventions which we believe will have a tremendous impact on reducing HIV incidence. Clearly, we are very interested in improving access to health care, and much of our efforts to scale up HIV testing are focused on ways in which we should be linking people who are diagnosed with HIV to effective and high-quality care. We're working differently with our community-based programs, and we're partnering differently with other federal agencies to look at issues related to access to care. Finally, we're looking at all of our programs at CDC to address health-related HIV health disparities, whether in our health department program or community-based organization programs. In all that we're doing, we're looking critically at the needs of communities, engaging communities to identify high-priority needs, and targeting the resources where they're needed to have the greatest impact. We're also using demonstration projects to really fund innovative efforts to look at combination prevention in some of the highest hit jurisdictions within the United States. Some of you may have heard of the 12 Cities project, which has been funded by the CDC, which really looks at intensifying prevention resources in the 12 hardest hit jurisdictions in the US to look at scalable models for both addressing health disparities and reducing HIV incidence in the United States. And finally, CDC recognizes that we cannot do this by ourselves, and over the last 6 years, we have completely changed the way we engage communities in a new national conversation about HIV/AIDS under the umbrella of our Act Against AIDS initiative, in which we have created both a leadership initiative as well as a national social marketing campaign to again engage the hearts and minds of Americans of all walks of life, but specifically minority communities across the country, in a new conversation about HIV/AIDS. So this brings me to the end of my opening comments this afternoon. Again, it's just a delight to be here with you. I wanted to provide an overview of the US HIV/AIDS epidemic. I wanted to talk about the importance of reflecting on some of the social and structural factors driving the epidemic in the US today. And I wanted to end by thinking ahead, thinking about the new vision for the national, articulated by the National HIV/AIDS Strategy, and articulating ways in which CDC is committed to changing the way we do business to meet these new imperatives and a new vision for HIV in the US. Thank you.
I am so glad the CDC is finally getting here. I think I'm the only one who was in that staff meeting the day those first 6 cases were presented to CDC. And I remember thinking, this is one disease I'm not going to touch with a 10-foot pole. Because everybody was excited about it. You know, this was something new. And if there's one thing a biostatistician learns is he stays out of the way of stampeding physicians. So, and it was kind of interesting because one of the first hypotheses about the HIV epidemic was that it was due to poppers, which is an inhalant that gay men apparently use during sexual intercourse. Because they couldn't conceivably think of, it was not biologically feasible to consider the possibility that there was a virus. And so, by accident, I was called to talk to a person in Birmingham who had simply observed that hepatosuppressor ratios were lower among some hemophiliacs than other hemophiliacs, and developed what I called anyway the hot lot theory, which is that there was an infected lot of hemophilia factor that was associated with this lower hepatosuppressor ratio. And needless to say, that went over like a ton of bricks. The idea that it could have been a virus was ridiculous as far as people considered, and anybody who would suggest such a thing were one of these people who just looked like numbers and didn't understand disease. Well, it turns out it was a virus. So looking at numbers might be a good idea to think about how to work with diseases like HIV. The next instance is when I had a little concern in Florida, in southern Florida. There was a little town called Belglade, and just not too far away from that, there was a young woman who had contracted. I have slides, don't I? Let's see, up or down? Oh, yeah. Okay. There was a young woman who had contracted HIV, apparently from her dentist. She was young, attractive, middle class, well educated, and therefore the nation, the media went crazy about this particular case. And it knocked off the front page of a little town just a few miles up the road, Belglade, in which we saw the first major heterosexual transmission in this country. It was in Belglade that you were going to find a real case of what was going to happen in the United States and what to do about it. And it went ignored because the media pressed on this one nice, and I have friends who are nice white ladies, but that's what the focus was, and the result was we didn't pay sufficient attention to what was happening in Belgrade. That was a tragedy. We made mistakes in this epidemic. So I already did that one. Okay. Then later on, it became clear. Now, I don't know whether I should do this, but I'm going to do it anyway, because he's close to retirement, and I don't think they'll fire him from CDC at this point. But the first person to observe that AIDS were higher in African Americans and European Americans in this country was observed by Dr. Alula Hagu, who actually had to, how should I say this nicely, extract data from the data system at CDC because he was not going to be allowed to look at them officially. And in the end, we could not get that data out of CDC. On the one hand, as one senior manager says, well, black people got enough problems. They don't need this. And on the other hand, black leaders were saying that this is no way possible. Black people never get AIDS. So you shouldn't even suggest this. We finally got that paper out of CDC, published by someone else here at Morehouse. And from that, we were able to, in 1986, call for the first conference on AIDS and minorities that I co-chaired with another person who would pay the price for trying to push forward this issue about AIDS and African Americans. And in that first conference, I can remember Don Hopkins trying to tell the audience that whether AIDS started in Africa or whether it didn't start in Africa was unimportant, and whether black people get AIDS was unimportant. The issue was there was a fire in the house. That was the quote. And unfortunately, that was not immediately appreciated. And in fact, a small study was done in New Orleans not too long after, in which HIV in New Orleans was much lower than one would have expected it to be. And we didn't know why, so we went to New Orleans and found out. I didn't. Another person did this. And found out that there was an old law in New Orleans that allowed clean needles to be bought at drugstores. And so they published that in the Times-Picayune is the name of the newspaper, I think. And the result was that the religious community was up in arms and changed the law so that you couldn't get clean needles from drugstore in New Orleans. And what happened? The HIV epidemic went up. The ability of the what I call traditional Negro establishment to deal with this epidemic was horrendous. Horrendous. And that is one of the things that I think we need to look at in terms of where we're going forward, and I'll get to that. And finally, in 1990, I published this paper which simply looked at the epidemic among African Americans and the epidemic among European Americans in this country. Now, the epidemic in European Americans was primarily among men who had sex with men. The epidemic in African Americans were primarily with men who have sex with men and IV drug users. But heterosexual IV drug users tend to have sex with women. So the HIV epidemic was going to be far more important in the African American community than in the European American community, and that because the epidemic would be somewhat limited within men who had sex with men community, and the HIV epidemic in the black community would spread out across the general population, clearly the rate of disease in African Americans would substantially increase over time. I had to write the paper, although I knew I was just going to be frustrated. The fact of the matter is this. African Americans historically have not made good European Americans. No matter how we've tried, we just don't seem to be able to do that very well. But African Americans make very good African Americans, and that's a good thing. So the issue is there are two different cultural phenomena going on. There is not one AIDS epidemic in America. I think that's crazy. There are many epidemics in America running parallel to each other, and we've got to think about this in that way. That's a very different way of thinking about it. And I think when people say it's the AIDS epidemic in America, they miss a very, very important point. There are actually parallel epidemics in America. And therefore, the approach to these parallel epidemics need to be different. So I just want to make that point. We started, or myself maybe, started a program, because like I said, I did not want to get involved in HIV, although I got sucked into it anyway. A program called Syphilis in the South. We observed that syphilis was a safe disease to work in, but we could study it in a way that might reflect on what we should be doing with HIV disease. So we decided to look at syphilis, and we found that syphilis was primarily in 26 counties. We could identify those 26 counties. We could fund community involvement in the elimination of syphilis in those 26 counties. Thanks to support from Dr. Satcher, who provided the first funds for us to do this. And the result was that we were actually able to reduce the rate of syphilis in African Americans in this country. That's extraordinary, because most health disparities, as you know, we've not really made an impact on. If you look at infant mortality over the last 100 years, the infant mortality rate ratio of blacks to whites in 1900 was 2. In 1940, it was 2. In 1970, it was 2. In 1990, it was 2. In 2010, it is 2. We have not affected health disparities in 100 years. And in 1895, they said what we need to do is produce more physicians, more hospital, more health care. In 1940, we said we needed to fund public health departments and produce more physicians and do more access to health care. And in 1980, we said the same thing. In 1990, we said the same thing. In the year 2011, what are we saying? The same thing. What happens when people who do the same thing over and over and over again expect a different outcome? What is that? What is that? You know, we need people to think. That's why I'm so glad that there are young people in this audience, because that's what we've got to do. Most people are locked into traditional thinking, and trying to get people to think outside the box is enormously difficult. You know, so I won't stay too much on that right now. So I thought about this hierarchy community participatory research, which we learned from syphilis in the South. By the way, once we started reducing health disparities in syphilis, the money was shifted to do more testing, for developing more sophisticated tests for syphilis. So the whole idea of syphilis south changed. Frustrating, but okay. It's okay. So this hierarchy indicates that from the very top, we should at least go in the community and let them know that we're doing the research, right down to actually doing work that the community wants us to do. And we've tried to do that in the last few years, where we just fund communities to think about the research that they want to do here in the state of Georgia, and then proceeded to get support for them to do the research they wanted to do. That's the kind of community participatory research that I think we ought to be doing, rather than what we're doing right now. But you have to remember, one of the best community participatory research projects in the history of the United States was also the most unethical medical research study in the history of the United States. It was the Tuskegee study of untreated syphilis in a Negro male. That program was started in Macon County, Alabama, because Macon County, Alabama had physicians at a hospital, black-owned and managed hospital, and it could carry out the treatment programs for syphilis, which included mercury, bismuth, and arsenic. Now, treating with mercury and arsenic has a few problems. Yes. Like it'll kill you if you don't do it right. So that was a little bit of a problem. You had to have trained people to do it. That's why they started in Macon County, Alabama. But they ran out of money. And so they decided to follow these men for 3 years to see how not funding this program caused health problems and therefore would justify getting federal funds to start the treatment program. The 3 years went to 5 years, then 10 years, then 20 years, then 30 years, and it went to 40 years before the men ever got treated. Because you could start out trying to do a good thing, and it could end up horribly wrong. And that's what happened in the Tuskegee study of untreated syphilis in the Negro male. And just to point out, it was a community participatory research program. They did notify the community they were doing this study. They got endorsement from businesses. They got community advice from Tuskegee Institute. They actually got consent from the physicians, predominantly black physician medical society in Macon County, Alabama. And it did start because the community wanted to do something about syphilis in the community initially. So, you know, and it was culturally competent, which I think, you know, that is another one of those issues. People talk about cultural sensitivity. Cultural sensitivity scares the crap out of me, to tell you the truth, because what's important is not cultural sensitivity. It's cultural humility that's important. If people go into a community with humility, they will develop sensitivity. And if they go in there thinking that they know about a community and its sensitivities, and not be humble, they are not going to do a very good job. I don't care how much training you do. We have to rethink these issues from cultural sensitivity to cultural humility. So, now, I'm a biostatistician, so, you know, I have to talk about data. There are some things that data suggests that we don't want to believe. Access to health care is not very important. Acceptability of health care is hugely important. If you look at Atlanta, because you know the Buttermilk Bottom and other public health projects that were in downtown Atlanta were moved out to the suburbs, and those people now have to go back to Grady. They passed many sophisticated major medical centers to get back to what they call the Grady's. And they call it the Grady's because it was two Grady's, one black, one white. That's why they call it the Grady's. And if you work in the community in Atlanta, you will know that they call it the Grady's. Well, they pass all these hospitals to get back to the Grady's. Why? Because they feel accepted at the Grady's. Acceptability of health care is important. Now, I'm not saying accessibility is unimportant in rural areas and in some other situations, but acceptability is critical. The next thing, race. Even if such a thing did exist, race is less important. Racism is important. And most people are scared to death to even say the word racism. I mean, people start mumbling when they say racism because they're so uncomfortable about the word, and yet it is a major factor in understanding how health disparities occur and how the HIV epidemic occurred. Culture is important. Culture is important. Believe it or not, African Americans are an ethnic, believe it or not, African Americans have history, value, culture. I know most people believe that African Americans are solely defined by their skin color, and that's very unfortunate. So I don't even use the word race to describe anybody. I think it's inappropriate. So, anyway, and the other thing is we don't collect data on race anymore. Since 1986, it would be very difficult to find a system that collects data on race. If you fill out the census form, and you could check whatever you want. If you want to check white, check white. You can check white, and you can go and get a driver's license. Trust me, I know this. And you can check white, and the state trooper wouldn't say a word. So you could be, it's identity, it's how you identify yourself, ergo ethnicity, not race. You know, in the 1960s, when I first started out collecting data in the community, the person came to the door, and we had a form, and we looked at him and said, "Look black to me." You know, that doesn't happen anymore. Okay. The other thing is, 87% of African Americans are biracial. I used to lie about this, but even I had to admit, whatever. Paul Dickinson, married this African woman, married for 47 years together, and I still used to deny his existence. All of us, 87% of us have had these things. So biracial, is crazy, insane things. So here's what I think is happening. This is the model I think is happening in the United States. Socioeconomic status, more than 30%. Racism, a little less than 30%. Culture, a little less than 30%. Medical care, maybe 10%. Genetics, 1%. Genetics is important to the individual's health, but to the group, it is relatively unimportant. There's a difference between individual genetics and population genetics. And yet, when you look at where NIH is spending the money, genetics and medical care. So if you're putting all the money into the two things that have almost nothing to do with health disparities, what is going to happen? I mean, these are intelligent people. Why did they do that? You have to ask. You have to ask. So, Tuskegee study started with the idea of doing treatment and went to the denial of treatment. Because even after penicillin was discovered and utilized in the United States, they were denied the treatment of penicillin. Community participatory research, we started out thinking we were going to do community origination, and now today a bulk of community participation are simply clinical trials to ask the community to participate. So it'll end up in the same way the Tuskegee study ended up. The clinic turned it into a clinical trial. Health disparities research, we started out thinking we were going to do social determinants. And what it's degenerated into is a focus on genetics and medical care. It's unfortunate. Unfortunate. So I want to talk about some failures, and then I'm going to quit in just a minute. Okay. I say traditional Negro thinking, but, traditional political thinking, medical thinking, whatever. Max Robinson was a TV anchor person who died of HIV disease. And I remember a very famous preacher from Chicago who gave an eulogy on national television, 7 minutes and 26 seconds. And in it, he talked about Max Robinson not being gay, not an IV drug user, a good man, true, and all this sort of stuff. But he never said, community, this is something that's going to develop in our community. And it was a lost, incredible moment. I will skip to what we should do and then quit, okay? Because I know people always shut me up. It's okay. I'm used to it. What we should do is invest in institutions with a long history of focusing on underserved communities. As you know, Harvard is now a minority institution. You know? And it is now being funded as a minority institution by NIH. You know? And it's a lot better to say I funded Harvard than to say, you know, I funded, you know, Morehouse. You know? So, you know, we have to ask about this. There must be investment, and I went to both institutions, okay, so I don't have to hang up on them, you know. Invest in programs specifically directed to alienated communities, not the ones that are just politically safe. You know, when I lived in West End, I lived right across from the street from a motorcycle gang, and I wanted to fund the motorcycle gang to do HIV prevention. Needless to say, it didn't go over very well in director-staff meeting, you know. But we've got to take a risk on funding people who actually know what the communities who are at high risk are doing. And that takes risk. It is not safe. And finally, we have to invest in programs that really develop minority researchers. Right now, there are a lot of training programs that have gotten to the point now where we used to invest in students who had potential, whatever their GPA was. Now, training programs, for the most part, only want to fund the students who were going to make it anyway. So they could say, well, we were successful. You know, so that most training programs do squat because they only fund the programs in the schools who were going to do what they were going to do anyway. That's a kind of thinking that troublesome to me, you know. And I think that right now the SC Division is investing in some research and minority researchers, and I think they need to continue to do that. I would be very, very, very upset if they didn't. Okay. So this is what we should be doing. And it's not just black. You know, I've focused, you know, to a large degree on African Americans, but it's not just that. This is the group of epidemiologists who did the work that showed that African American women were at greater risk of preterm delivery in the United States. I love this picture. And it's just not because I married one of them, but, you know, I just love this picture, you know? And so I'll leave this with you because I think that this next generation, you guys, you know, next generation, that's where the hope is.
Well, let me join in welcoming you to the Morehouse School of Medicine. We were hoping to have at least a half an hour left for discussion, but Bill Jenkins is back. And you know what that means. No, seriously, I think Dr. Fenton and Dr. Jenkins have done such an outstanding job. And I wanted to get to Dr. Vega, and she reminded me that they have us in order, and they would have to adjust the slides. Can you do that? I mean, to get to hers. Yeah, because I want to make sure that she has some time here. Okay. Let me just briefly, there are one or two stories I do want to tell about, I guess I'm probably the oldest person here on the panel. And so I have memories that probably some people don't have, and I'll be very brief with them. But I do remember 1981 when the first cases were identified, I guess, in Los Angeles with the help of the CDC. And a lot of confusion back in that time, a lot of stigma. As we tried to move forward. I remember visiting Africa in 1986 really as a part of a group to drill wells to try to prevent the infections from unsafe water. And one of the things I remember most about that visit was the opportunity which I had to meet with UNICEF. And they had a statement in their pamphlets that I've reflected on many times since then as we ask about this new disease of AIDS in Africa. And it basically said the most important thing that we could do to reduce the spread of AIDS in Africa would be to educate women. When I think about that, you know, we've had the commission which I served on, Social Determinants of Health, but how far ahead of their time they were. They saw even then that the fact that women were not being encouraged or sometimes allowed to go to school in Africa was a major problem for AIDS transmission, because it had a lot to do with power and whether women actually had power to negotiate safe sex. There are a lot of other barriers to that power too, but certainly education is one of the major social determinants of health, and it certainly has played out in this pandemic that we're dealing with now. Another memory which I have, about the same time, a little later, the Secretary of Health and Human Services visited Meharry where I was president. His name was Dr. Otis Bowen. He had been governor of Indiana, and everybody called him Doc Bowen. But he came to Nashville to talk about this new disease, fairly new. And he had trouble getting somewhere to speak. Vanderbilt was not interested in having a conference on HIV/AIDS at that time. So we invited him to speak at Meharry, and just an overflowing audience. People were interested. He was really moved. He did a great job. And then when he got back to Washington, he told President Reagan about this great experience that he had. And that was really when I was asked if I would serve on the Commission on Graduate Medical Education, and I ended up chairing it. That's how Bill Clinton, he read the report that we had done and asked me if I would serve on Mrs. Clinton's Committee for Health Reform. And that one thing led to another, and I ended up director of the CDC. Really interesting. It wasn't that easy, but but it's around this. I've had so many experiences around this issue of HIV/AIDS, and so I just have to reflect on that. At the CDC, I do remember that we had about 8 different AIDS programs. And Claire Broom and I decided that we needed to bring these programs together. But everybody had their turf. Nobody wanted to give up anything. So we asked a very beautiful but tough young lady to lead an effort to bring them together. Her name was Helene Gale. She did it very well. And after she did it, we decided to make her director of this new institute, the National Center for HIV, STD, and TB. Now, I know the name is longer now and has this outstanding director, and Kevin Fenton, but there's some real history there. Helene Gale, of course, has done a lot of outstanding things, including with the Gates Foundation, and now heads CARE, the largest humanitarian organization in the world. The other experience, which I think is really relevant to this discussion of social determinants, is that we are funded, I believe, 36 programs throughout the country to evaluate the impact of needle and syringe exchange programs. Dr. Jenkins talked about the drug injection problem in terms of the spread of this disease. So the idea was to see if we could provide clean syringes and needles to people who were using drugs, if we could reduce the spread of HIV. It was a well-done study. There was no question about the outcome. The provision of clean needles and syringes dramatically reduced the spread of HIV, and there was no evidence that it increased drug use. So we sent that information to Washington. And then when I got to Washington as Surgeon General, we talked about it, and we were going to call a press conference because we had talked with the White House, and they had said they were going to support federal funding for needle exchange programs. And I think the night before, somebody said to President Clinton, do you realize that you're not going to get the votes in Congress to pass this, and then they're going to use it against you? later on. So the next morning, we were waiting to have the press conference, and an hour before the conference, we got a call from the White House telling us that President Clinton had changed his mind. You know, being Surgeon General and Assistant Secretary for Health was quite an experience. There were very few times in which I had to be schizophrenic because as Assistant Secretary for Health, I had to support the administration, but as Surgeon General, I was at liberty to speak out, and that's what I did. I went out of that meeting and all over the country speaking out about the importance of needle exchange program, and many states and many localities funded them. It's a long story, but it's interesting. It was only last year that Congress passed legislation not for necessarily for federal funding for needle exchange program, but they called it it's sort of a revised ban. In other words, states could use federal money to fund needle exchange program. They didn't have to. And so, as you can imagine, some states used the money and some states didn't. But very interesting part of this. But this country has a stigma, you know, as it relates to sex, stigma related to drugs, and certainly when it comes to HIV/AIDS, it is the victim of all kinds of stigma as it relates to sexuality and drugs. And so there are people in Congress who believe that if people are using drugs, they deserve whatever they get. And they're not willing, and they have the idea that anything you do to help, you're just going to be encouraging them to use more. We proved that that was not the case, but that didn't change attitudes. And the last story, of course, is about J.W. Lee, who was just an outstanding leader in public health with WHO, and led major efforts in terms of polio and malaria, TB. He became Director General of WHO a few years after I left government. And in 2005, I received a call from JW. And, you know, I was under the impression, you know, that since he was Director of WHO, we're going to really pursue some of these things he had been doing. And he told me, no, David, I want my legacy to be the social determinants of health. So he asked me to serve on this commission, and I did, and we went all over the world, looking in some cases, like at Chile, where they had decided to invest in education of children from 3 months of age on. They were put in daycare. It was paid for so that if there was a teenage mother and she wanted to go to school or go back to work, she could. They provided health care. I visited some of these schools, and good nutrition, all of those things were built in. Chile made a decision that it would be a better investment to invest in the health and education of these children than to build hospitals, that it would be better in the future for their health and more affordable. And so they had a tremendous model. There were some other models that were not so good. When we went to Kenya, in Nairobi, we visited the largest slum, I think one of the largest in the world, and over 500,000 people in that slum without running water. And they had these little AIDS clinics, and it was just had a skyrocketing rate of HIV infections. And the government, which we had met with the day before, had said that they were considering building a new hospital. And after we visited that slum, we strongly recommended that the government invest in running water for people in the slum, in education for the children in the slums. And they listened, in part because the Minister of Health went with us and was on the commission. So, as Dr. Fenton said, we must attack the social determinants of health. We must make sure that our children are educated. We must make sure that people have access to decent work, livable wages, dignity, and all of those things that helps to make people proud of who they are. What we see at Grady, and Dr. Yolanda Wembley runs the STD clinic, and what we see are people coming back to that clinic over and over again with the same infections, not because they don't know, you know, they've been educated over and over again, but some of them feel powerless to negotiate safe sex. Some of them have been abused when they were children, And therefore, their concept of themselves and their dignity and their value is very low. We've got to deal with all of these things if we're going to overcome this epidemic. We've got to deal with all of those things that prevent people from exercising power over their lives or even feel that they deserve to be healthy. Those are all things that relate to the social determinants of health. And so I think that I'm delighted with the approach that the CDC has taken. I'm very pleased with the outstanding leadership that Dr. Fenton has provided. And I think the country is now beginning to move in the right direction, as you've heard, with that strategy. And of course, CDC had a lot to do with that. So I'm going to stop, and we're going to hear from Dr. Vega, and you can take care of it. Thank you very much.
Thank you. It's always hard to go last, especially after this distinguished panel of speakers here. And also right before keeping you all from dinner, perhaps. I'm going to try my best to do the New York Puerto Rican speed talk, but that you can still understand me. I actually feel very humbled to be in this distinguished panel here and with you all to talk about this very important anniversary. I've been in the field at my current position for 8 years, and I've been learning a lot from everyone here. And I'm going to start by talking to you a little bit about my own personal journey and that of my mentor, Dennis De Leon, who was the head of the Latino Commission on AIDS, which is the organization where I'm the vice president. The organization itself is a national, local, and regional service provider that does HIV testing. It also does prevention programs, health promotion. We do research there, and we also do advocacy and community mobilization. So we try to be an organization that addresses the epidemic from a very holistic point of view, addressing both the needs in the community and trying to bring light to it at the federal and national level. I'm here today to talk to you a little bit about the role of community partners and what a partnership with a CBO and grassroots organizations can mean in this fight. In the 1980s, in the South Bronx of my childhood, it was the epicenter for AIDS in New York City, with one of the highest AIDS infection rates in the city, if not the country. Even during the early stages of the epidemic, when AIDS was stereotyped as a gay white male disease, the disproportionate impact on the poor, on minorities, on the disenfranchised was readily visible in my neighborhood. Oftentimes, a sickly individual would be described as looking like death, and whispered speculation as they passed by on whether they were gay, a drug user, or had that AIDS thing. But the world I grew up in was the world of the marginal. Access to food, to shelter, to education, to a safe space was never assured, let alone access to adequate health care or social services. I was one of those that often did go hungry at times, and I saw that firsthand, and saw firsthand how people had to fight to get food, even wait in what was called, quote unquote, the cheese line in the neighborhoods. The crime, violence, drugs, and social breakdown attendant on the urban poor further exacerbated the impact of AIDS on the community of my youth. What we at times refer to as infrastructural barriers is truly about survival at the margins and good fortune or the luck of having a caring parent, a local champion, albeit a gatekeeper, local leader, or local organization, can quickly determine the difference between individual resiliency and descent back into a cycle of poverty. My mother, a proud Puerto Rican who had little education of her own, yet valued it enormously for her children, and a community-based organization called A Better Chance, which perhaps some of you may have heard of, helped me get out of the South Bronx and attend an elite private boarding school called Phillips Academy, where I got to be with the wealthy, the elite of society, and I also got to see pictures of George Bush as head cheerleader when he was there. So that was invaluable in itself. But this move meant I was no longer surviving at the margins, but had started my journey as a cultural broker where I navigated two or more different worlds. I thrived and developed what researchers refer to as resiliency. Most research now shows that resilience is the result of individuals interacting with their environments and the processes that either promote well-being or protect them against their overwhelming influence of risk factors. Embedded in those environments are the community-based organizations that I myself was touched by. So what is the role of community partners? The role is to be the arm that reaches into the community and pulls people up and helps address poverty, access to education, access to care, and serves as a conduit, catalyst for breaking down those barriers that can lead to health inequities. I pursued a Ph.D. at Berkeley, where my research began to focus on stigma as a barrier to healthcare, as this was what I saw firsthand in the Bronx, although back then I didn't know that's what it was called. And I began to examine how this insight could be applied to more effectively assist communities at risk. I wanted to take all my past and apply it right at the community, and that is where the CBO came back into my life at the professional level, and where I met the great Dennis de Leon, who unfortunately is no longer with us in body, but I know he is with us here in spirit. He was the founder and leader of the Latino Commission on AIDS, and as such, he became a national figure that fought for the hopeless, helpless, and marginalized, and to restore and renew communities. He saw Latinos and others at the margins, and he wanted to pull them in. He wanted to help build social capital and create conditions that make it possible to improve the quality of life. He was a lawyer by training, a past human rights commissioner, and a fighter. There was no fight for equality, social justice, or resources that he would back down from. And that he instilled in me, and I hope to keep moving forward. And at the root of community partnerships are other fighters, and that's what we're here to do in this partnership, is to keep all partners aware of what's going on in the communities, and when people won't listen, when people don't have a voice, we're the voice of the people. So, community-based organizations are cultural brokers for the communities they serve and have positive ripple effects far beyond their official missions. Community-based organizations are frequently the glue that helps hold communities together, helps communities survive against long odds, and they create resiliency, address structural barriers, combat stigma, and serve as community champions. As we have seen from the other speakers, resiliency and combating stigma are key to addressing this epidemic. Quoting de Tocqueville from the 1800s, he noted that Americans of all ages, all conditions, and all dispositions constantly form associations of 1,000 other kinds, religious, moral, serious, feudal, general or restricted, enormous or diminutive. I have often admired the extreme skill with which the inhabitants of the United States succeed in proposing a common object for the exertions of a great many men and inducing them voluntarily to pursue it. The term CBO, this still holds true today, and we now face extraordinary demographic shifts in a melting pot that he could have never have conceived of, and the ability to form these associations and integrate into communities is more important than ever in our society, as the National AIDS Strategy, which Dr. Fenton talked about, also notes that it is imperative to develop and maintain these public and private sector partnerships. The term CBO can encompass anything from primary health care agencies to community centers. but they share the common characteristic of integration, access, and understanding of a local community or a specific population. They are familiar, culturally responsive to their local community and its environment. It is not a question of whether we should use CBOs as a partner, as their use is a fact. CDC has directly funded CBOs in prevention efforts for many years. The question is how to further increase cooperation across all levels of government and communities to meet our shared goal of a world without AIDS. So where have we been? The community-based organization historically has been in the vanguard of HIV prevention program implementation. HIV prevention programs frequently were designed based on local knowledge rather than explicit empirically validated theories, and as such, oftentimes were referred to as homegrown interventions. We have swung a little bit away from homegrown interventions, and I'm here to propose that we need to go back to funding some more of those homegrown interventions. Thank you. CBOs have been also at the forefront of advocacy for research, access to services, and attention to the impact of the epidemic on underrepresented populations. Let's look a little bit at the timeline of CBOs in this fight. 2 years into the AIDS epidemic, 45 groups were formed in the U.S., mostly organized by gay men. By the end of the first decade of the epidemic, more than 600 community-based AIDS service organizations had sprung up around the country. Since 1988, Congress has mandated direct funding of CBOs to provide support for HIV prevention infrastructure in underserved communities. In 1997, the CDC directly funded 94 CBOs under Program Announcement 704 to develop HIV prevention interventions. This year, or I guess last year, the CDC funded over 130 organizations to provide HIV prevention services. So definitely the number of CBOs has gone up, although I think last funding cycle it was a little bit higher. So the international, federal, state, local, and community-based organizations share a common goal to reduce the impact of HIV/AIDS. Ongoing biomedical advances, which we heard a little bit about today, and we should be very happy and enthusiastic about, invaluably prolong lives and make life better for those already infected. But we live in a harsher reality where the mere existence of a biomedical advance does not mean all have access to it. This means another essential weapon in our arsenal must be structural, community level interventions along with the continued efforts of behavioral interventions and programs. In terms of behavioral interventions, any reasonable psychologist, me being one of them, will assure you that there is no such thing as a one-size-fits-all behavioral intervention. Behavior is intertwined with cultural norms, and we ignore this in the prevention field at our peril. In a country of such rich diversity as the United States, behavioral intervention must be adapted to social and cultural contexts to be effective, particularly when dealing with ethnic, minority, and marginalized populations. Few entities are as well positioned as community-based organizations to address this need. CBOs are the boots on the ground, staffed by individuals who are part of communities who could tap into those communities effectively and mold prevention strategies for increased effectiveness in the communities they serve. The U.S. is now at a social-cultural crossroads with demographic shifts that are rapidly changing the public health landscape, placing current models of HIV prevention at risk of becoming irrelevant or counterproductive unless we address new realities. These realities exist at the community level and require community-based expertise to determine these practices. Local organizations continue to persevere, maintaining an energy and sense of purpose that has allowed them to create innovative strategies tailored to their communities in spite of the many challenges associated with the provision of HIV/AIDS services. Let's talk a little bit about the challenges, if we can, for a few minutes here. For many in this field, it is a calling. As we've heard from our distinguished panelists, they've been in this field for a long time. And others in CBOs, for example, you will find people who have been there for over 10 years. That is great that they feel such passion and such calling, but sometimes that also leads to burnout. So we're also seeing immense rates of burnout in this field, and we have to think of creative ways to address that, to make sure that the workforce can take care of itself while taking care of others as well. And part of some of what's leading to this burnout, we did an assessment of service providers and service providers in Rhode Island, New York, Connecticut, and Puerto Rico. And these are some of the buzzwords that came out from the focus groups and from the surveys. And this little chart here has key phrases here, and one that I want to highlight, or a couple I want to highlight here, is the wearing of multiple hats. As we've been told, we have to do more and more with less, and that means that more and more individuals in the workforce have to take on multiple positions, have to not only now do outreach, but then they have to do the testing, and then they have to enter the data and do the evaluation and so forth. And all these enhanced new skill sets, many of them refer to this now as a knowledge economy. And we're actually seeing this overall in the United States as well, as we see, factories closing in Detroit and other fields being impacted. In HIV/AIDS, you often hear now that people are saying, God, at this point you're going to need a Ph.D. to do outreach. And what they mean by that is that there are more and more skill sets being demanded of the workforce, when CBOs, at Essence, has started off as being very grassroots and being of the people, for the people, and now it seems like where are the peers going to be in this time? So where are we going? There's a need for a combined systems approach to prevention programs so that there are multiple access points, multiple types of interventions targeting our communities, structural and individual behavioral interventions. There are promising biomedical approaches on the horizon that need to be coupled with community-based approaches along with increasing access to care. I cannot emphasize enough the need to increase access to care. Right now we know, for instance, that about 34% of Hispanics, Latinos, do not have health insurance. And Hispanics and Latinos are extremely late testers, meaning that they often get dual diagnosis. So within a year of being diagnosed as HIV positive, they have progressed on to AIDS. And that means that their quality of life and their longevity of life may suffer as a result. So going forward, we have to think about how do we get all these new promising approaches to the community. There's a continuing role of CBOs as implementers with credibility in the community. So even if biomedical approaches become widely used prevention methods, we still have to rely on CBOs to make these approaches palatable to the communities. And again, let us not forget the need for homegrown interventions and solutions as well. The creativity and responsiveness of the communities needs to be able to shine through. While as a psychologist and an evaluator, I do believe in evidence-based interventions, I do think that we can help communities develop these evidence-based interventions. And we have to come together to leverage those resources to make sure that these interventions are also coming from the ground up. So in closing, I'm going to end with Maslow's hierarchy of needs. It's not simply a menu for individual happiness, but rather represents an integrated picture of a whole healthy person. Doctors and medical researchers address important physical health needs. Community-based organizations more typically approach health issues as part of a more integrated picture of individual and community needs. The role of the CBO is addressing health inequities in addressing health inequities is precisely this, to see the whole person and addressing a whole set of interrelated but different needs, all of which contribute to promoting health for an individual and through them, their communities. Thank you for your time and keep fighting the good fight.
So please join me in giving all of our speakers a round of applause. We really want to thank you for an outstanding presentation, and we know that everybody benefited from what was said here. Unfortunately, we are really tight on time. I think we had such a great time that, of course, time is coming to an end, so we probably have about 15 minutes for some questions. So what I'm going to ask is that if you do have a question, please say, we do have the mic here, if you would step to the mic and ask your question. And if you could tell us your name, that'd be very helpful.
Check. Mic check.
Yeah.
Y'all hear me? Splendid.
Yeah.
Good evening, everyone. Mm-hmm. My name is Omavi Bailey. I'm a third-year medical student in Havana, Cuba. I'm a Morehouse man as well. Mm-hmm. I was taught by Dr. Jenkins. And it's good to see you all today. I really appreciate all the presentations that I heard today. The question I want to ask is really more so related to the question of the brain drain. And that's really all. I ain't going to ask a whole bunch of questions. But I think that when I heard the discussion about having more researchers, but then researching for the interest of whom, you know, and how do we make sure that we don't have a brain drain even within our own communities? Do we have researchers who are interested in solving the problems that we have and really focusing on the health disparities that we're confronted with? Because we have a situation that is critical. Mm-hmm. And so how do we do that?
Anyone wanted to? Dr. Satcher?
I'm going to be brief, but I think our brain drain starts very early, and we're concerned about children who may not be getting the nutrition they need, the communication, the interaction at an early age. That's why I mentioned the Chile project, where they just made a commitment to children, especially children of the poor, and they made a commitment that we're going to invest in in child development and education and health. So I know we have brain drains at every level, but I think our biggest brain drain is taking place very early. And, you know, we ended up with a lot of people in prison who are there because they didn't get the early nurturing that they needed by our social situation.
I'd just like to say, you know, the United States has a medical care system. Cuba has a health care system. Yeah. It's a big difference, you know, and you could see it in the statistics as well as in the feeling that the people have about the health care system. So, but I think in terms of the brain drain issue, what has to happen is that old folks like me and young folks like you know, need to mentor the generation behind. Because right now, if we depend on major universities to make those investments, it's going to be limited. Many of them try to do it, but like I said, they want to invest in those who are going to make it anyway. You know, it is only by personal intervention that we find people who are willing to invest in people who have the potential, but who not necessarily, whose success is not necessarily assured.
Thank you.
So you.
Dr. Fenton.
Exactly. I just wanted to say that I agree with everything the panelists have said. And I also want to just broaden the frame, because I think the challenge is not only researchers, but also public health leaders as well. One of the challenges we're finding within our field is that when people think about dealing with health disparities or HIV/AIDS, especially young people today, their thought immediately goes to working overseas in sub-Saharan Africa, in Southeast Asia, in the Caribbean, rather than thinking about own disparities here in the U.S. and the incredible needs that we have, not only in our inner cities, in rural areas, but across the country. I think in addition to mentoring, I think it requires leadership. It requires leadership of people of color who have made it to positions of leadership to continue to pass the baton on with mentorship. But if we're going to get ahead of this, we need all leaders from all backgrounds to value the lives and contributions of minority researchers and minority professionals. And then finally, we need funding as well. And certainly, as a leader at CDC, I know that I have to make an active choice to fund minority fellowships and minority programs every year in the space of budget cuts which are facing us. It's not easy, but you require that leadership commitment, and that is something that I'm committed to continuing to do.
Thank you.
Hello, I'm Dr. Deborah McClendon, Emory Healthcare, and I would like to know a little bit more about the many epidemics that are parallel and the approaches needing to be different.
I think that's Dr. Jenkins.
Okay. Well, one of the examples I have is a terrible mistake I made. When CDC first provided the $3 million for funding community organizations, I was given responsibility for doing that. And the data says Hispanics had an increased risk of HIV disease, so we got in applications and we funded Hispanic organizations. The second year I realized we were funding, almost all of our money went to Cuban organizations, all the HIV were among Puerto Rican organizations. So, what we've got to do, I think, is, be able to analyze what's happening, a little bit more succinctly in terms of ethnicity. And that's why I really think that we should be collecting data. For example, the law requires that you have certain ethnic groups being identified for certain federal programs. But there's no law that says you can't be more specific than those ethnic groups. And I think that, what we've been trying to push is to collect more specific data on ethnicities and to see how this epidemic is working parallel within these different communities and to respond to these different communities in very different way. One of the programs we funded was from Central America, Graniferous. Graniferous. 100,000 graniferous in Brooklyn, right?
They're from Honduras.
They're from Honduras. Mm-hmm. And, I never knew that group existed. And their dynamics was very different than the dynamics we saw in other African American groups. So we really need to be that specific to the extent that we can.
Okay.
So I do want to just respond from CDC's perspective to demonstrate that we are looking at the epidemic in this way, both in terms of characterizing the epidemics, which we have in the U.S. differently, but also ensuring that our programs are responding. And, the great examples are programs now that we have, which are very distinct for IDUs, for heterosexuals, for gay men, but even in our MSM programming, looking at the needs of white gay men versus black gay men, and even within black gay men, realizing that the epidemic among young black gay men is incredibly different from what's happening in older black gay men in the United States. And really working with our community partners to develop those responses tailored to the epidemic. Mm-hmm. We know better, and so we have to do better. And I'm proud to say that we are doing better, and I would love to invite you, Bill, to come back to see our program at CDC today to understand ways in which we've really heeded your counsel and the challenges that you've made to us over the years about understanding the heterogeneity in epidemics and responding likewise.
Okay, thank you. And unfortunately, we only have time for one more question. Hopefully, our panelists might be available for some time, afterwards to ask questions. So please.
Thank you. Mm-hmm. My name is Daniel Driffin, and I work for a community-based organization here in Atlanta. I guess my question would be directed towards Dr. Fenton, more or less, and then I guess anyone else can jump in. With the National HIV/AIDS Strategy and the 12-City Project being really pushed into the community, and even the successful efficacy trials of the HIV prevention trial networks with the PrEP 052 and all those other numbers, do you see traditional HIV prevention beginning to battle with the biomedical side of HIV prevention, and then even treatment as far as the ADAP waiting list, which is still a problem today?
Yeah, so great question. So what I hear you ask is, with all these new data showing the power of antiretroviral therapy, not only to treat HIV, but also to protect people who are HIV negative from acquiring HIV, is there a tension between treatment and prevention, and what do we do in terms of the community space? So very briefly, I don't think we need to move beyond the or. It's about the and. We need to do a better job of scaling up HIV treatment in the U.S. The fact that we have nearly 8,000, 9,000 people waiting on the ADAP waiting list should not happen on our watch at this time. And we need to push and work as hard as we can to deal with treatment for treatment's sake, but understanding that it has a prevention benefit. At the same time, we have to look at these new technologies which are available. This is an unprecedented time to be working in HIV prevention globally, where we have many more methods to protect men and women from becoming HIV infected. So we need to think about, how do we look at these new technologies in the real world? How do we target them to those who need it most? And how do we ensure that we're combining the prevention approaches most effectively? I'll share with you one thing I'm really concerned about. All of these biomedical approaches, because they depend on the health service for delivery, have a real potential, I think, to accentuate health disparities, especially among people who poorly access healthcare services anyway. And so we have to be very, very mindful as we're developing these biomedical approaches, PEP and PrEP and so forth, that again, it's not going to the people who are using condoms anyway and reducing their risk behaviors anyway. We have to find ways of integrating all our methods to reach those who need it most.
Well, thank you very much. And I'm going to remind everyone, hopefully you have received the evaluation form. We really do welcome your feedback, and we'll hope that you will complete that. Also, I want to just announce that our next lecture is going to be held on Thursday, July the 21st. That's HIV prevention programs, perspectives from the front line. We'll be joined by Dazon Dixon-Jallo, who runs Sister Love, a major community-based organization in the area. Nina Smith Bankhead, who is the director of the Department of Education and Volunteer Services at AID Atlanta, and Jeffrey McDowell, who is the executive director and chief trainer at Atlanta Harm Reduction Coalition. That's going to be held at the King Center, Freedom Hall, and they'll also, I believe, be offering free HIV testing on site. So thank you so much again for joining us. We really appreciate that, and we hope that our speakers will have just a minute at least for you to ask some of your questions on the outside. Hope you have a safe ride home. Thank you.